Calcium Code, Navigating Cardiac Investigations with Dr. Tom Ford and Dr. Adam Bland. Now, for those of you that don't know me, my name is Sydney and I'm from the PHN Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For most of us on the Central Coast, that is Darkinjung land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. It is being recorded and will be available for you to view in our education library in a few days' time, as well as a copy of the PowerPoint PDF. Now, as attendees, you have the ability to have your camera on or off, but we do kindly ask you to keep your microphone muted for the duration of the session, and at the end, we'll have a live Q&A. The chat box is also live, so if you want to pop in any insights throughout the presentation, please feel free to. And at the end of the session, you will receive a link and a QR code to our Slido evaluation. As your feedback is so important, we'll pass it on to the presenters as well as go through it as a team so that we can look at future education for you. All right, it is my great pleasure to hand over to Dr. Tom Ford and Dr. Adam Bland.
Thank you so much. Well, we're excited to be here. I'm particularly excited to share this talk with my colleague and friend, Dr. Adam Bland. Adam's recently relocated to the Central Coast, and first and foremost, I think we're good friends. And then secondly, I guess we've got the same kind of values, really putting the patient first and delivering what we feel is high quality care. And I think we're confident we can hopefully help to look after local patients. And so if you see our name, welcome to come and say hi. So today, really, it's a 40-minute talk, and we're really keen to make this interactive. We've got some clinical cases that I actually enjoyed putting together, and Adam's going to talk through some of the imaging aspects. And my background with interventions, we're going to maybe talk about some of the invasive aspects of their treatment. And we're really hoping to help you navigate through the challenges of different coronary tests, because there are quite a few. And this field has evolved rapidly, and it's been developed through randomized trials. So we're going to look at some of the two major randomized trials that's helped to inform practice. And then we're going to talk a little bit about the nuances of investigation in the local environment, local to the Central Coast. So we're going to start off with a clinical case. We're going to talk a little bit about the three major tests, which are cardiac CT, stress testing, and then definitive coronary angiography. We've got a few more cases to illustrate different situations with high calcium scores and low calcium scores. And then finally finish off with some learning points and practical takeaways. So without further ado, this case was very fresh in my mind because I saw her just before Christmas, and it was a 58-year-old fitness trainer that came in, has never had chest pain, but something was feeling unusual during high-intensity exercise. She'd had 6 stereotyped episodes in total with dizziness and nausea during high-intensity exercise without palpitations. Does have a family history, but was very clean living. And the cholesterol profile you can see is mildly abnormal, but not suggestive of a genetic syndrome. The resting ECG, interestingly, did show some minor abnormalities. And like a lot of patients, this was someone that was sent to me fully worked up. And the reason for presenting it is just because the interpretation of all of these tests is very subjective. And the learning point for me as a specialist is that perhaps the most diagnostic accuracy is when you're listening to the patient. And when I was listening to this lady's story, I was concerned that something was not right. There were clearly exertional symptoms, but no chest pain. And I think this ECG at rest is enough for me to be worried about myocardial ischemia with anterior T-wave changes. She managed to almost complete the Bruce protocol, which is the standard way that we exercise these patients. This was the ECG at peak exercise. And I might see if Adam has any thoughts on this. Is a summary of the ECG. On the left-hand side of the screen is the resting ECG, and on the right-hand side of the screen is the peak stress changes. So what do you think of that, Adam?
So yeah, if all of you at home, as you can appreciate on the right-hand side, there's some ST depression in areas. In particular, if you're looking down at sort of 2, 3 and ABF, that bottom left corner there, you can appreciate that that is ST depression, and laterally at V5, 6. We get more concerned when it's looking more horizontal, even downsloping in the trajectory of that ST depression. So the inferior changes in particular are more concerning with that sort of horizontal ST depression that's going on there.
So electrically positive stress test and reproduction of the patient's symptoms. And then with a stress test, typically we have two facets, or three facets: the clinical story for the patient on the treadmill, the ECG, and then this is the stress echo pictures.
And so again, if you look on the left-hand side, that's at rest and peak on the right. And we'd like to see all areas really becoming hyperdynamic or moving in nicely as they exert themselves. And on the left-hand side, so that's the lateral wall. It's a four-chamber view, but on the lateral wall, that's moving nicely. The septal wall is a bit of abnormal conduction movement, but it's that's all moving. And same on the right-hand side, every area is increasing in movement appropriately. And so there's no obvious sign there that there's a perfusion defect causing hypokinesis anywhere. Moving on to the next pictures, that's the two-chamber view, getting at your anterior wall on the right and your inferior wall on the left. And again, all walls are moving in nicely at rest and moving in appropriately on exertion. It gets a bit harder on exertion with movement, but it's all moving in appropriately.
So I guess it illustrates the challenges of looking. I mean, it's not a binary thing. In my mind, perhaps the inferior wall is a little bit hypokinetic, but it's quite subjective, and that's the reason for showing the pictures. Is it really is a judgment call. And in this individual patient, managing 15 minutes on the treadmill is quite a good prognostic sign. This was a test reported in Sydney at an external radiology practice, and I guess these types of reports, they may be doing, 10, 20 reports every single day, and it maybe just highlights that perhaps the diagnostic accuracy is not what we would want. And this was the summary of the report, which in my mind, if it's not really summarized in one sentence, it's usually that they're not sure what's going on. And so this type of report maybe isn't going to lead to a clinical suspicion of coronary disease. So it said stress ECG positive, stress echo negative. So really, what do we do? And I put this, this was an AI generated image to illustrate maybe some of the gender bias. So this is a female patient without traditional risk factors. In my mind, her stress test is highly abnormal. The ECG is definitely abnormal, and she's got very real symptoms, but we managed to talk our way out of diagnosing this as a problem. And so she came to me with this stress test report, and I thought, let's do a cardiac CT. This was my notes at the time. It was just before Christmas, CT, and, I was a bit concerned, started her on a beta blocker, and I've got the CT pictures that Adam might talk through.
Yes, for those of you who haven't seen too many CTs, this is we sort of can reconstruct the images and have a look, and you can see quite proximally in that's the right coronary artery. There's a lesion, which I'm just highlighting over there, and you can appreciate that degree of stenosis, which is called a severe stenosis in that territory. But there's zero calcium in that area. So there's if that person just had a calcium score, that wouldn't pick up on any abnormality at all. That's purely soft plaque. That's more common in younger people.
Correct. So soft plaque means it's happened recently. It's not happened over years, which is consistent with the history, and a much, much, much higher risk of future events. And so whilst it's true that not all narrowings need a stent, this is someone who hasn't got stable angina. They've got unstable crescendo angina and a very high risk of future MACE. So maybe if we base this patient's treatment on the stress test alone, I would argue that maybe we could have missed this. So there are some risks to doing tests if we're not interpreting them in the context of the patient. Managed to get this patient into the public hospital 2 days before Christmas, and you can see that same lesion on the right-hand side. This is a catheter called an OCT catheter that allows us to look inside the artery, and I've got a video of what we see inside this lady's artery. I'll need to switch off the pointer, and we can press play and watch what we see. Incredible. So this is light technology that's displaced blood, and we're viewing the inside of the lady's heart arteries. Clearly, this is a fairly normal part of the vessel. And then what we can see, we've got a kind of really critical narrowing. And I'll just highlight that inside this narrowing, you can see different textures. And I would suggest that this highlights what we know is the natural history of mild narrowings that become unstable. They bleed, and they can rapidly change from 30% to 90%. And I guess she would have had a heart attack if the stars had aligned and that she had sticky blood, thrombotic milieu. But as it were, she had a relatively fixed but critical stenosis and relatively healthy landing zone. So this would be a type of perfect case for for a stent, and one where we would argue, so we put in a stent, this is a repeat image, and we know that the stent is on the wall. This technology reduces the risk of stent failure by 50%. And so I think this should be the standard of care for most PCI procedures. And just a picture of the before and after, we can see we were able to fix her up. She feels great. So we can stop the beta blocker. She's got normal LV function. But a case that illustrates a couple of important learning points, mostly listening to the patient, and you guys are experts with thinking about the patient in front of us. CT has a really good negative predictive value in severe disease. And Adam's pictures with the CT scan were, he called me up and said, Tom, this lady's going to need an angiogram. And obviously the diagnostic accuracy of a test depends on the context where we perform it. And in this case, listening to the patient, we were convinced something was not right. Also, we'll talk a little bit about gender bias. It's really important in cardiology. We know that the big group of patients which don't have the best outcomes is younger females. Every other group of patients has improving cardiac outcomes following heart attack. And I think a subconscious gender bias, this case illustrates that, because they had a clearly abnormal stress test, but because they were a middle-aged female without traditional risk factors, there was maybe a bias that we weren't able to call the stress test as abnormal. And the patient didn't ever have chest pain, but had critical coronary disease. So that's an important take-home message. The calcium score of 0 doesn't equate to 0 risk if there's other risk factors and they've got symptoms. I might stop there because it's a really fascinating case with some really good learning points. Georgia or anyone, does anyone have any questions or comments, or Adam?
Yeah, Diana had a question, and especially you said the gender bias in females as well. So what would make you do a stress test versus a stress echo? So Diana said that she usually does a stress echo for women, and I must say I do the same thing. So can you comment on that, please?
Yeah, if it's just as test availability, there's no advantage to not doing a stress echo, really, at all, that I can see, other than the fact that the windows sometimes aren't good. If you've got a really obese patient with COPD or something, it's very difficult to see the heart. But it's more about access to the testing. And historically, you'd have to have an echo tech, etc. But we've got really good access to testing. I don't know, do you see any role for a stress ECG more over a stress echo?
Not really anymore. I think with the availability of echo, it gives us more information to help make an informed decision. We know that in particular, stress ECG can have a lot of false positives. So to have that stress echo gives us more information to really equate it all together, and false negatives too. So I think it's a benefit to get both in we have available.
Yeah. Okay, so in the interest of time, we might move on. I wanted to talk just a little bit about the evolving nomenclature for chronic coronary artery disease. And this is really a kind of overview of ischemic heart disease in the current era. We can present in an acute fashion, as per the first case, or in a chronic fashion. But what I wanted to highlight to you is that patients may or may not have underlying obstructive coronary disease. And so in obstructive disease, that's well recognized as a cause of angina, but we can have angina without coronary blockages for a few different reasons. The main ones in stable disease would be microvascular dysfunction, more common in women, and vasospastic angina. And similarly in ACS as well. I just got a phone call from a local specialist that said his partner's had a heart attack in Japan. She's a middle-aged female. She's got no coronary blockages. She's got MINOCA. So this is a evolving nomenclature which maybe wasn't appreciated 10 or 15 years ago, which splits up the treatment of coronary disease into the presence or absence of obstructive disease. But the learning point as a GP would be, if you get a negative test but someone's got a good story for angina, it still could very well be angina, which is a clinical diagnosis. So an interesting evolution there. The forefather was the person who characterized the syndrome is this guy, William Herberdin, who derived, the feeling of angier, which is derived from Latin chest pain to strangle. But interestingly, this guy was an Englishman, but it was a Scotsman, Alan Burns, at the University of Glasgow. And it was Alan Burns that hypothesized that myocardial ischemia was the root cause of angina. And it's a really important clinical problem. It's really common, a 3 to 4% prevalence of adults, certainly in the UK. and a substantial number of hospital admissions and healthcare resources. What we're really looking for is obstructive disease. In this case, we've got critical stenosis of the left main. And this focal disease is well suited to stenting. But what we want to highlight to you is that there's a diverse array of causes of angina and ischemia. And not all patients have coronary blockages. This was someone with angina and ischemia. And what we don't see on the angiogram is the microcirculation, which is so important, thinking about it like a tree analogy. We've got the twigs and the leaves that they drive the nutrients to the tree, but we really only see the major branches. The two conditions that can cause angina or ischemia without coronary disease is microvascular and vasospastic angina. And importantly, anatomical tests, an angiogram or cardiac CT, do not detect these conditions. But the guidelines, how we practice, have evolved, and through some of the work that's been done in the last 5 years, guidelines now support testing for these disorders, but it's rarely done in clinical practice. And this was just an infographic highlighting the numerous different types of pathology that can explain angina, not just a stable focal blockage, diffuse disease, small vessel disease, bridging and spasm of arteries. And it's not just the heart as well. We've got to think about systemic causes, things like high blood pressure. If we've got severe valve disease and high blood pressure, that's enough to cause angina with no coronary blockages. So just to highlight the importance of thinking about the individual patient in front of us, optimizing their blood pressure, making sure their heart rate's controlled. Atrial fibrillation is another example with rapid ventricular rate, that the endocardium, the area of the heart muscle closest to the LV cavity, is often starved of blood when the heart's racing. And we would see often ECG changes and angina syndromes without coronary disease in arrhythmic patients like AF. So I don't know, Adam, if you want to sort of talk through an approach to angina, which is obviously a clinical diagnosis. Do you want to?
Sure. So I guess when we assess angina, there's a number of ways to go about it. First and foremost is obviously the history and trying to assess their symptoms. It's a thorough history, a thorough examination, and you're trying to really rule out anyone that needs to be escalated into the hospital because they have quite clear unstable angina, or at least a quick phone call to your local cardiologist to sort of get them in reasonably quickly. We have to think about other causes of chest pain. Is there something else going on with the history and exams? Could it be a PE? Could it be an aortic syndrome? And then depending on their pre-test probability, I guess we have the diagnostic test of best fit, and whether that be a person needs to go to an anatomical test like a CT, or whether we think they're best suited to a functional test like a stress test. And all of that comes together with the history, with the clinical presentation, with their risk factors, family history, all those types of things. And then, as mentioned before, it breaks up into an anatomic or a functional test. A CTCA is our non-invasive anatomical test with a coronary angiogram being our invasive one, which obviously some people need to be escalated to if they're quite unwell. But functional tests, we have a number of them: stress ECG, stress echo, like was discussed before. We also have nuclear medicine, which we use a bit less. It's more common in other parts of the world, but I guess we tend to use a little bit less. But it's still a functional test we might use at times.
And never wrong to go straight to an angiogram if the circumstances are right. And I think probably these days the risks of an angiogram, certainly in a low-risk patient, a 50-year-old, we would quote 1 in 1,000 for a life-changing risk. But really, touch wood, in 6 years from a diagnostic angiogram, I can't recall a stroke, a death, a major event like that. Of course, we consent for it. It can happen. But if you've got a high-risk patient and you're worried, the buck stops there. You can have one test where you get an answer, and I think a lot of patients value that certainty. Also, patient factors that Adam mentioned, severe obesity. If you've got a patient that's 160 kilos, heart rate's 100, you're never going to get a diagnostic CT. And if you do get a CT report, are you going to be able to trust it? So there are some patient factors, but I wanted to highlight a key slide about maybe looking at the pre-test probability and how that would impact our patient testing choice. Low-risk patients, if you're not concerned and they've got no risk factors and it's not cardiac chest pain, it's reasonable not to do further testing and just to optimize their risk factors. And for an intermediate patient, like the patient that I first presented, fitness trainer, some risk factors, some symptoms, I would argue perhaps a CT was a better test for that lady. And if we weren't concerned clinically, we would have missed that problem, definitely, because the stress test was basically reported as negative. And in a younger patient, we're going to get better pictures with less calcium. And on the CT, calcium makes it difficult to be sure what's going on. Whereas in a intermediate risk older patient, maybe thinking about stress testing, because the older patient population has a much higher burden of coronary calcium. And we're going to show a case that illustrates the challenges that we see with calcium. And therefore, a stress testing might be a better situation where we're going to find significant lesions, but not overcall calcified narrowings. So we will come back to that. The things that favor the use of cardiac CT is someone that's maybe a relatively, certainly a body weight under 120 with a resting heart rate, which is pretty good. Faster resting heart rate make it more challenging. I don't know if you've got any comments on the heart rate assessment, Adam.
Yeah, so there's a number of, I guess, artifacts with CT which make the results more difficult, and calcium being one of them, but the other one being any kind of motion. So if somebody's heart rate's a little bit quick and difficult to control, that can result in different degrees of artifact, which can make things challenging. So we do try and get the heart rate ideally into the 50s with a CT coronary angiogram. So if someone comes in, like Tom mentioned, with a heart rate of 100, it's going to be quite difficult to get them down, particularly if they're in, say, atrial fibrillation or something like that as well. So we do beta block these people, reasonably aggressively to try and improve the quality of our scan, to improve the quality of our reporting.
What do you think is the big advantage for you as a doctor when you've got a CT report versus a stress test, for example, in the first patient? What do you think is the big benefits to you as a doctor to help with the patient?
I think there's a number. I guess firstly, we are looking for obstructive disease, so it gives an idea of that if we can comment on that. So as mentioned before, if we get a calcium filled study, sometimes that's difficult, but we can also see the degree of plaque and see where it is. So it can determine how aggressive you are. It's a great study if you've got a 45-year-old who are expected to have no plaque, but it turns out they've actually got quite a bit of soft plaque. And from that, you can choose to be very aggressive in there. Even though they're not obstructive, you can choose to then be very aggressive in your lipid management and whether you need to put them on aspirin, depending on how severe it is. But I think, and also the discussion showing the patient saying, look, you have a lot of plaque, you can see it right here. We should really think seriously about statin therapy, for example. And I think these are important ways to interpret the test.
That's a really great point. So I think the key take home is that you get additional information, not just on obstructive disease, but on non-obstructive disease. That means that we can better target patients at risk. And that's a really key point. The other things that Adam in the last 2 weeks just called me up, right, with really interesting non-cardiac findings. So there's a patient that's got a large atrial septal defect with breathlessness. I'm going to do an angiogram on her today. Because we can close that. The chamber dilation makes you feel breathless, and it's a non-coronary finding on a CT scan. And another thing we picked up was a PE in a friend. Someone had come for a heart check. He's in his mid-50s, just being on a skiing trip, and he's got bilateral kind of significant PE that Adam had picked up. So, it's definitely non-coronary stuff is great. And we obviously there's the incidental lomas, which can be a difficult challenge. If we request a test, I would like to think that we would action them on behalf of the patient. So, incidental pulmonary nodules, but other things like lung disease and other causes of breathlessness, we often get a good steer on. So it is a really great test. The things that would make us think more about stress testing is if they've got lots of calcium, that makes CTs less likely to be diagnostic. Stress testing gives you some symptom correlation. And the patient who was the fitness trainer, she had a reproduction of symptoms. That was very helpful. And it helps us to find ischemia. So those would be the big ones. If if we used CT in a patient with normal arteries, we could miss things like small vessel disease, which is a cause of a false positive, should we say, stress test, where we get ECG changes. So hopefully that kind of clarifies the two different kind of patterns of CT versus stress testing. But ultimately, the guidelines support both of these tests, depending on local availability and clinician judgment. I guess these are our opinions, but everyone would have a different bias and feeling on things. There's two recent studies I want to briefly touch on. Adam's going to talk through the PROMISE study. Adam, do you want to?
Yeah, so these two large studies are really in the CT world. When it first came out, or it's been sort of more known about the CT coronary angiogram in the last 15 years, there was a lot of promise to this, but this is it's the PROMISE trial back in 2015, where they recruited over 10,000 patients with symptoms of coronary ischemia for either non-invasive workup or a CT coronary angiogram, for a non-invasive workup with either CT coronary angiogram or some sort of stress imaging, being a stress ECG, stress echo, or a nuclear stress test. Similar to a lot of our trials like this, mean age 60, around 50% male, female, 87% were symptomatic with the typical symptoms of chest pain, exertional dyspnea, 2-year follow-up, and the primary outcome being a composite of death, myocardial infarction, unstable angina requiring hospitalization, or a procedural complication, particularly from the angiograms. That's just similar on the demographic we mentioned. You can see over 60% are on have hypertension, 20% diabetic, mean BMI of 30.
They're mostly about 60, weren't they, with a good distribution of women?
Yes, yeah. If you get the next slide.
Yeah.
A lot of people on therapy to baseline, even 45, 46% on statin therapy at baseline.
And they were all symptomatic, weren't they? So it wasn't asymptomatic patients, it was patients who could conceivably have angina.
Yes, yeah. And this is the main result, is that there was no significant difference at the 2-year mark between functional or anatomical testing. One of the main criticisms of this trial was actually there's a pretty low event rate in general of having in both groups. And perhaps that might reflect some of the population. However, at 2 years of follow-up, there wasn't any significant difference in that composite, which I guess pulled a little bit of steam out of the CT direction. But then we went on to the Scott Hart study.
Yeah.
A couple of years later.
So the key difference in the PROMISE study was similar outcomes between stress testing and CT. No difference in death, no difference in heart attack, no difference in hospitalization. More angiograms in the CT arm, which is kind of reflective of what we would see, because we're seeing more plaques, but it didn't really change the outcome. And radiation was quite similar. Scott Hart was not unsurprisingly done in Scotland, where we've got a lot of coronary disease. And these were the key questions that were being asked by the investigators. It was a slightly different study because standard care in Scotland is quite hit or miss. And so these were patients that had CT versus standard care. And standard care was traditionally a stress test and medications. And so the primary endpoint was major adverse cardiac events, but they also had an angina sub-study. And there was a quality of life study that was quite interesting as well, and it's really important for our clinical practice. These were mostly male patients with a similar age to the PROMISE study, around 57. We've just got data out to 10 years. The 5-year data was presented at 5 years ago at a New England Journal. But Scott Hart found a difference in death from heart disease or non-fatal MI, and it was predominantly driven by non-fatal MI. There was roughly a 20% reduction, an absolute risk of reduction of around 1.8% or thereabouts. So number need to treat here would be fairly high, at least 50 patients to prevent a heart attack. But the key thing was that we were detecting plaque because revascularizations, stents were similar between the two groups, but we were really targeting the medical treatment much better. We were stopping treatment maybe on people who didn't have plaque at all, and we were more aggressively treating non-obstructive disease, which Adam pointed out is a real strength of CT. The overall survival between the groups was quite similar. but that's the bottom right of the slide. But the non-fatal MI was really what drove events. So almost a 30% reduction in MI, which was predominantly from procedures. What was really interesting is the subgroup analysis of male versus female. And this really goes together with the first case, because this was a lady that presented without chest pain, but certainly had symptoms that could conceivably be angina. And with stress testing, it was maybe overlooked. And we talked a little bit about a potential gender bias, whereas CT, you cannot argue. You know, you see Stevie Wonder could have seen that narrowing in our coronary artery in the CT scan. So certainly it enhances the ability to detect patients that have disease, especially if they present in unusual ways. And so that was really interesting, that the benefit was more driven by women than men. And a little key summary of the differences between these two studies. But these are in the guidelines now, and the take-home point is there's probably not a huge difference between the two strategies, but perhaps over the long term, especially in younger patients, detecting non-obstructive plaque is really helpful for advising the patient on their long-term risks and treatment. So better for prognosis with CT, maybe better for symptoms with stress testing. I don't know what you think.
Yeah, I'd agree. I think your younger patients where you can treat things aggressively, and particularly those ones that have an potentially higher risk plaque, there's probably a benefit to CT. But again, we lose that benefit as we get a bit older and pick up some calcium, and I think a little bit. So yeah, I'd agree.
So we've got a clinical case of case 2, an older patient, 75, who was just generally a bit tired, probably had familial high cholesterol. The peak LDL was 6.4. The calcium score was up. So quite a common presentation, you know, possibly asymptomatic, mild symptoms. Symptoms are really difficult though, aren't they? It's like working out what's normal and what's not. And sometimes, you know, putting a patient like this on the treadmill is not unreasonable. In her case, she went straight to CT. This was my case. I think we've just got one picture, but maybe you can talk us through what you think, Adam.
So you can see, just on one slide, it doesn't come through perfectly, I'm sorry, but you can appreciate sort of the proximal third of that vessel. There's a shelf of calcium. There's some patchy other areas down the vessel, but particularly that shelf of calcium just there where Tom's hovering over, which makes it really difficult to see. And then after that, you've got an area of hypoattenuation where you think maybe something's going on there. It's certainly something you would be looking into at different angles and views if you could.
Yeah, so this was reformatted. The feeling was it was at least moderate. The patient underwent a coronary angiogram, given it's a prognostic vessel and she's got some symptoms and what looks like a severe lesion there. But on the angiogram, which was straightforward and uncomplicated, really the plaque there is very mild. So there's no severe luminal narrowing. She's clearly not someone that's going to benefit from a stent procedure. And, you know, she's had a procedure which gave us a definite answer, which is good. But again, you know, invasive procedures, you know, do have a downside. And I guess this case illustrates maybe in the older patient, perhaps I could have used a stress test and just reassured myself. The other thing that we've not touched on is quality of life after a cardiac CT. Scott Hart had a sub-study on quality of life, and it is impaired at 1 year compared to standard care. And it may be related to an awareness of your own mortality, that you've got this irretrievably high calcium score. There's nothing that you can do about it. It will never go to zero. And it's just a reminder of a patient's morbidity, but it led to definitely impairment in quality of life. Most people, though, would rather know, but, you know, there's some talking points there. And the other learning point from this case was that calcium on a CTCA may overestimate a stenosis, and we showed that severe on the CT. We looked on the angiogram, it wasn't severe. Great, so we're well over halfway there. We've got about 10 minutes to go. I'm opening up for questions just as a little interlude.
Yes, we do have a few questions coming through. So Diana made a comment more in regards to the first patient who was likely postmenopausal. Do you have thoughts about HRT estrogen on the effect of the heart?
Yeah.
Current reading is it might be protective perimenopausally within 10 years of menopause, but after 10 years, there may be a risk of cardiovascular disease. So what are your thoughts on that?
I'm supportive. I'm very supportive for the patient population for my PhD, which was of different angina syndromes, probably in small, improves endothelial function. And I guess the absolute contraindications, you know, are relatively small, right? It's a shared decision making. So in terms of the risk for the individual patient who's never had an atherosclerotic kind of ACS event or a PE, I think it was probably going to reduce the risk of future events. Certainly it can improve angina and quality of life. So those would be, you know, really important patient-focused endpoints. But perhaps we're moving back to the future where historically there was a dogma, you know, heart disease, you know, the pills or the hormone therapy is a no-no. My feeling is I'm quite relaxed about it, especially if there's a quality of life benefit to the patient. If there is a risk, it's for patients that have had previous events. I don't know if you've got any thoughts, Adam, or colleagues.
Yeah, similar. It's the cases that I've seen have been more, and like say they've already had an event. There's been the worry. So yeah, I think people do get a lot of quality of life benefit from that. So I'm supportive.
What do you think, Georgia?
Yeah, look, I do have a patient that is on HRT and was given and she has had cardiac events, but was given the go ahead to continue with the cardiologist. And as you mentioned, it's all about quality of life as well. So she hasn't been able to successfully wean off the HRT, so we're keeping going with it, and she's having regular checkups with a cardiologist.
Yeah.
And there was another question about if you could explain bridging, please.
Sure. So bridging is a relatively common phenomenon where traditionally the arteries go across the top, model, so across the top of the muscle. In the next slide, I'm actually going to show you a case of bridging, but it's quite a common phenomenon. Perhaps maybe as much as 1 in 5 patients have a degree of bridging where the artery dives through a superficial layer of the myocardial muscle. It doesn't traditionally have any clinical impact on the patient because the coronary flow occurs in diastole, so systolic constriction of the vessel doesn't actually affect flow. But increasingly, we're aware that probably the pattern of flow down a coronary vessel is important in driving future events. And so we do see that the changes in the friction of blood on the vessel wall is different in these patients. The next patient that we're going to present illustrates that, but it can associate with propensity to vessel spasm. And so we definitely see a higher incidence of coronary spasm in patients with bridging, and it may relate to the changes in blood flow and friction, which causes some endothelial impairment. So again, it's an evolving area of interest in the scientific community. Most cardiologists don't really have a great understanding of myocardial bridging because it's really quite an evolving field. There's a whole subspecialist area of testing these bridges, and we can do different types of invasive tests on them. But in most cases, the mainstay of treatment is we don't stent them, we don't operate, we just treat them with medications.
Great. There's a question about referral pathways that we might leave that towards the end.
Sure.
And then just comments about CT being preferable perhaps for women to stop the gender bias and interpretation of stress tests. And then another question was a patient asked Diana if the mild soft plaque can be reversed if found on scan. She's been counselling patients that's more likely to prevent worsening and plateau. Can it be reversed is the question.
Well, yeah, there is some evidence of plaque regression. We're going to talk about this case that's probably relevant. And in answer to your question about the CT in women, I think the two tests are complementary because CT, you could argue, is going to misdiagnose people who have angina from small vessel disease because you're going to say they've got non-cardiac symptoms. Whereas if they've got, you know, an abnormal stress test, it can be complementary. So in my mind, the two could be used together. this is a really fascinating case. And actually, I think one of you on the call shares this patient with me. So I'm really happy to look after this young man. But his case is really enlightened my practice. He's got familial high cholesterol. His dad died of a heart attack in his early 40s, and he's a young dad. The cholesterol of 10, triglycerides of 7, LDL above 5. And this was a CT. Unfortunately, we can't reconstruct it. But I don't know, Adam, if you've got any thoughts on the CT, which was reported as normal with a calcium score of 0 in 2017.
Yeah, look, the images are we have some improvement in technology over time too. So some of our image acquisition can be a little bit improved. As much as looking at this, there does hint to be in the proximal vessel a little fraction of a shelf, and perhaps there's a bit of soft plaque.
So we're looking here. So normal vessel, normal left main. Here we've got what appears to be slightly moth-eaten to my eyes, and perhaps here hypodensity in the vessel wall. This is normal, right? Normal vessel here, but this is clearly not the same caliber. So, you know, it's a 3D structure. It's clearly not a flow limiting lesion, but there's some plaque in this guy's artery, right? There's definitely plaque in the artery. And what we also see here is some bridging that was, so the LAD is outside of the muscle. This is the LV wall. And then it dives in just a little bit. You can see the caliber of it changes and then it goes back out. So it's quite a common phenomenon. It can be associated with upstream disease, interestingly. But let me get the pointer away and we can go through the case. So some really good learning points. That's just a different picture of the same artery. So if you just had a cursory look, you would say, yeah, no severe blockages, but certainly some vessel wall thickening, some intimal thickening, and perhaps some plaque. The other vessels looked okay. And he was counseled to start a statin and his care was good, and this could have happened to any cardiologist. But I don't think he took his tablets. He was kind of intermittently maybe having a few cigarettes as well. And in light of his normal CT, he elected not to take his tablets and then presented about just a year after with what in my mind is a normal ECG, out of hours to Gosford emergency. And this could have been any of us. Said, look, classic reflux type symptoms, you know, and the story from the patient and their wife was so telling because he was actually he was off the monitors, troponin was negative, he was walking out of the door and he said, I really don't feel well, had a cardiac arrest, and his ECG showed tombstone anterior ST elevation. So a normal ECG, suddenly abnormal. Almost certainly he'd had a plaque rupture. What we know about thrombolysis is actually, this was when we were just starting the lab 6 years ago, the out of hours stuff that maybe we should have been doing 20 years ago, but we thrombolized the patient in emergency and it worked immediately. So illustrating that thrombolysis is still a very good treatment for young patients at low bleeding risk who've got recent onset symptoms. And it worked amazingly. The ECG normalized and the angiogram actually is difficult to see. So that's the picture of the proximal LAD. Let me put my pointer on and show you. This is the proximal LAD up here. There's a plaque rupture there. I'm going to slow it down just there where the arrow is. And it was fixed by my colleague with a stent. And then at follow-up, I guess we've always got different views, but the cardiologist thought, look, completely normal. It would be unlikely to be a plaque rupture. I think I would disagree. I think a 40-year-old with genetic high cholesterol almost certainly had a plaque rupture. And what we know and what you know now after today's talk is that coronary events are typically asymptomatic. They're relatively common that we've got a mild plaque that can rupture. Most of the time that will be asymptomatic unless the stars align. So perhaps a 30% mild narrowing that we saw 2 years ago became a 95% plaque rupture that had caused an immediate issue. So really fascinating case, illustrating the importance of clinical judgment. Thinking about the patient's family history is so key. And this patient, dad died at 42. The ECG and acute MI may be normal, maybe normal, maybe normal. Those are the three key points there. And this is another case illustrating the young patient with a calcium score of 0. So really sobering case. And I don't know if anyone has any questions on the case or any comments.
There was a comment about what percentage of people at any age and sex have soft plaque who have a calcium score of 0. I suppose we are doing a lot more calcium scores now, and are we falsely reassured when they're 0?
Yeah, it's a difficult one. I don't know the answer to that. Adam, what do you think?
I couldn't give you the exact answer. We report a number of CTs in my sort of imaging training, and there'd only be a handful last year that we actually had complete soft plaque versus severe lesion. But there's certainly lots that have soft plaque that's in there's certain characteristics that make it sort of high risk for having an event like this. And there's quite a few that have soft plaque lesions that need to be addressed and aggressively treated. But, the last 12 months, I'd say I've seen, including your one, 4 or 5 out of, 400 or 500. But yeah, I couldn't tell you the exact number, sorry.
But it's a good learning point that, perhaps if we predict the future, Georgia, what we might see in the field evolving is, historically it's been the calcium score. We may reach a stage where a CT has a non-calcified plaque burden score. We did a recent audit on acute coronary syndrome patients that I led with a great local medical student. And what we found is that for patients that had presented with a heart attack, we went back through their chest imaging, and about half of patients had incidental coronary plaque on CTs done for other reasons. And so perhaps an opportunity to intervene earlier. But if I were to predict the future, I would think we're going to start to see non-calcified plaque burden scores, and perhaps the use of AI in more accurately quantifying, like that case that we presented, the vessels that have non-calcified plaque, because that really is someone that would benefit from statin, not to treat cholesterol, although he did have high cholesterol, but to stabilize plaque. And we do see plaque regression, that we get stabilization. A 40% blockage may become 30. It's never going to be 0, but it's more about the composition of plaque. So some really cool points to discuss, and it's exciting to hear where the field might go. And the final case is about, the benefit of CT in identifying low-risk patients. This was a patient I saw who had AF, some funny chest symptoms during AF, was on long-term rosuvastatin, did a CT, completely normal arteries in a 72-year-old, calcium score 0. So this is a great example that we can reclassify someone at risk. Taking a lifetime of statin, if you need to, is fine. But really, I think in this case, guidelines would support deprescribing, and she felt better to stop the drugs. I'm really happy to help patients stop the drugs. So we've got some key takeaways that we can go through. Calcium score of 0 does not mean 0 risk. That was quite clear. The high calcium score does not equate to severe disease or severe stenosis, and it certainly can associate with anxiety for patients. The patient context, we talked about symptoms and listening to the patient. And in the case of the fitness trainer, she really, it wasn't like she was asymptomatic. She knew something wasn't quite right. If we've got a really good quality CT, we've got a very high predictive ability to rule out significant coronary disease. But of course, we've seen a couple of tests today where the reports were reassuring, but you've got to remember the individual patient. And for us as cardiologists, it's never wrong to look back at the tests. Functional testing, like stress testing, is good for older patients, especially if they've got a high calcium score, and perhaps tailoring the patient to the individual. So with that, I wanted to embarrass Adam. This is him in a picture from Gosford Hospital. He was on Channel 9 News last year with his research study that we did together at Gosford, looking at streamlining angiogram procedures. That was Gabby from Channel 9 News. We've got 2 practice locations in North Gosford and Tookley, and our goal is really to grow our diagnostic work, because we think that we can offer a really great service. And an example of that is, a local GP that called me and just before Christmas said, "Oh, I've got this patient with critical aortic stenosis," and if we had done the scan, we would have actioned it and sorted it out. We were able to get that patient sorted. I did the TAVI 2 weeks ago, and she's going well. But hopefully you would agree that there is value from seeing the patient and performing the tests, or just performing the tests in-house. We support local staff, and we're proud to be local, and we value really high quality care. So with that, thanks to Adam. We really appreciate you being here, and for the invitation, Georgia and colleagues.
Thank you so much, Tom. I'm sure everyone has got many take-home messages, and I especially love that little summary slide that I'll be copying. There's a few more little questions as well. So, yeah, David asked, should everyone with a very bad family history be on a statin?
Yeah, in short, I think the answer would be yes. If we treated that at a population level, everyone who's got a severe family history, first degree relative under 65, should be on a statin. For an individual, I can understand it's upsetting, the thought of being on a lifelong tablet. Nothing's set in stone forever, and guidelines are changing. Treatments are available like Repatha and Leqvio that weren't available, so easily a few years ago. But for the time being, my answer would be yes, even if the calcium score is relatively low in a young patient, and even if the lipid profile is fairly benign. What do you think?
Yeah, I think so. It's something where we see such a major area that coming with large heart attacks that have had a significant family history. It's I mean, people that don't want to, you can rationalize by things like calcium score CT to look at the plaque, but it's it is an area that's a high risk.
Thank you. And then the other question, I think, was from Diana, just regarding referral pathways. So I think it was, more, can we refer patients for a stress test, and then they come back and see us, so they can be in within 1 or 2 weeks, or if we do refer to imaging to your centre, is it to see a cardiologist and then it takes longer for them to get in?
Yeah, well, we would definitely agree that if someone's got recent onset symptoms, they should be seen promptly. And we would typically each have 2 urgent slots per day. But also the point is that, if someone was referred for an urgent test without a consult, that would be fine as well. So getting a stress test within 2 weeks is generally not a problem. If there's an abnormality, we can action it very quickly. So, without seeing the patient, we feel comfortable to request a CT if there's any doubt, like in that case, but also to action that, and we can do that, even involving things like telehealth for younger patients to get them in and to get them seen.
Great, thank you. And any other questions, and feel free to unmute, put your camera on so we can see all your beautiful faces. There's lots of thank yous for a great presentation. So, okay, all great. Thank you again so much, Tom and Adam. That was fabulous. And I'll hand you over to Sydney to do the wrap up.
Perfect. Well, thank you guys. That was brilliant.
Thank you. We really enjoyed